New Malice at 5:30. Oh.
She's not gonna let you have it.
No, I know, she don't want me to have it. We'll bring the Mojave County Department of Public Health to order.
Okay.
Let's see what we have. Stand and do the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Maggie Wilcox.
My speaker here.
Marianne Salem.
Here.
Frank Labarge.
Here.
Dr. Nguyen.
Here.
Dr. Hendricks.
Here.
Supervisor Jean Bishop.
Here.
Terry Williams.
Here.
Donna Williamson and Kathy Bruck are absent.
Next item is the approval of minutes from the July 13th meeting. Does anyone have any corrections? Do we have a motion?
So moved.
Second.
All in favor?
Aye. Aye.
Any opposed? Okay. And we have the next item is the CD update from Anna Scherzer, communicable disease.
Sue, did we get a copy of the CD update to the folks? Yeah. All right, so you have it in writing. That's a whole lot easier than saying it all out loud. So as usual, we've had lots of busy activity, but the good news is that most of it has been ruled out. So we spent a lot of time finding out that things weren't as urgent and as alarming as they could have been. And the one warning here is since this meeting was postponed, the case counts that you see in front of you are through the end of September. So we've got a month and a half more of work fresh in my mind that I might actually be talking about a little bit. But some of the things to point out in just the disease counts, of course, are we're comparing this quarter to the past 2 years. And then also don't forget to look at that number investigated column, where we're looking to see the number of cases that we actually worked on to bring out those numbers of confirmed cases that are showing up for the year. So those are the two qualifiers there. As we go through some of this here, it's a good idea to consider the chikungunya, the dengue, the West Nile virus infection, and the Zika virus infection kind of together as one group, because those are all the mosquito-borne illnesses. And one thing that happens with some of these mosquito-borne illnesses is if you test for one, you're supposed to test for some of the others. So there's a little bit of overlap there in some of that reporting that you might or might not see right at the outset. Cryptosporidiosis is in there on the list, and the only reason I'm pointing that out, we had 2 cases for 2016. And the only reason I'm pointing that out is because Maricopa County actually had a pretty sizable outbreak. Started last spring, carried through the summer, is quieted down quite a bit, but they had well over 400 cases of cryptosporidiosis, a gastrointestinal illness that's passed through stool. And many of those cases were linked to recreational water parks and pools and the big parks that they have down there. So it's quite a sizable problem. And it's a story that seems to play over and over in different states, year to year, summer to summer. So we didn't see that problem here. Our 2 cases were not linked to what was going down in Maricopa County, but we did have 2 cases to count there. The one thing that I will mention about the E. coli, the enterohemorrhagic E. coli counts, is we have a count of 0 for this case count period. But actually, we did have 1 case of E. coli. The problem is that it progressed to a case of hemolytic uremic syndrome. And so it's counted in our case counts under the HUS. and it was a fatal case. It was a fatal infection. It was a grown man, actually picked up the infection in another state, was actually treated and sought medical care in another state, and actually died in another state. So there actually was one E. coli infection very far removed from Mojave County, and it comes up in our accounts as an HUS case as opposed to the E. coli infection. The Hemolysis influenza, invasive disease, we had 3 cases that counted last year, and I want to point out that one was in an infant, and it was a vaccine-preventable Hemolysis influenza type B. And as far as I know, the child survived, and the infant had received a dose of the Hib vaccine. So I guess the timing and the age of the baby was just a little bit off there. Influenza, those case counts are, of course, for the calendar year. And on the back, I'll mention a little bit more about influenza. But of those 300 cases that are counted there, only 5 are from this season. So they're from the calendar year, but we're only looking at 5 so far this respiratory season. And you'll see a little bit more about that on the flip side here. The RSV cases, same story there. The respiratory season just recently started. So of those 32 case reports that are there, only 1 are for the 2016 to 2017 flu season. All right, I think those are the highlights that I wanted to mention there. On the flip side of the paper, I've got some of the other events and activities that we've been involved with. And the first one, if you recall, at our last meeting, we were talking about a measles outbreak that had started at a detention center in Eloy, Arizona, in Pinal County. And we were following up with, at that time, I don't remember if we had had our second detainee who had been released. I know we had had 1 detainee at that point who had been released back to Maricopa County. In total, we ended up with 2 detainees who were there in the facility at a time when they could have picked up the illness and were released back home to Mojave County. So we followed those individuals to make sure that they didn't become symptomatic, neither one developed measles, and that was the end of the story for us. The one thing that did come out of some of that activity and some of that information being at the forefront of the news is that, I think this is the reason why, but we started to get a higher than normal number of reports from doctors who were concerned about vaccine-preventable illnesses that we don't usually hear about. So we got some calls from ER docs and whatnot for other types of illness like diphtheria. We got some additional measles calls. We had tetanus in there. We had some polio reports. All of them, in the end, were ruled out, and none of those ended up being cases of any public health significance. But the good part on our end is that we got a lot of practice with some of those other types of more urgent case reports. In late September, early October, and that means the very last days of September, and then early into October, we received a call about a potential cluster of illness or an outbreak of illness associated. The report came in as being associated with a restaurant in one of our cities. And the folks who were getting sick were a group of individuals, actually students, who were part of a student organization. And they had had an all-day meeting in this particular city at school. And one of the leaders of the group had brought in breakfast that they had made at home. So they had some casseroles that they brought in for breakfast. And lunch was ordered out from this restaurant that was in question. There were 14 attendees of this meeting, and that includes both the students and the adult leaders and anybody else who was associated there. And we were able to contact 12 of those 14 attendees and carry out some interviews. And bottom line, at the end of the day, of those 14 individuals, 2 we are not sure of their status because we were never able to actually speak to them personally, but we know that 6 of the others were ill. And the illness was a fairly quick onset. Most of them reported within an hour or 2 of eating lunch. They reported a diarrheal illness that usually lasted only maybe an hour, 2 hours, and then they were better. which, if you're in this line of business, is very unique. We've never seen that before. Usually you're pretty darn sick, and it's not diarrhea. It sticks for a little bit longer. It's usually a different story. So we were never able to determine the causative agent of this outbreak, if it indeed was tied to this event. But we looked into it as closely as we could. We were able to identify 31 food items and determine that none of them, through some of what I do, none of them are considered to be a high risk in the end with the statistics, a high risk of being the source of the illness. So we looked at the breakfast as a whole, we looked at the lunch as a whole, we took the different casseroles that were served at breakfast. None of those were more dangerous than the other. It was a restaurant. Most of them had ordered sandwiches. We went through and we decided, or we determined what was on each of the sandwiches and even the separate parts of the sandwiches. Cheeses, meats were looked at separately. The spreads were looked at separately. We didn't find any particular item that was a smoking gun. Our inspectors went out and took a look at the restaurant just to make sure things were okay, and things were good. So there was nothing at the outset that really concerned us right off the bat. And nobody there sought medical care. They weren't that ill. Nobody was hospitalized. Of course, nobody died. And there's no definitive evidence of what these folks had or where it came from. And there's no supporting evidence that it came from that breakfast or that lunch, although it's a bit suspicious. Influenza. So for the 2016-2017 season, the first case in Arizona was identified in an adult resident of Pima County, and their specimen was taken in late September, and they got better. They were not hospitalized. It wasn't a serious infection, but it counted as our first locally acquired case of influenza for this season in Arizona. Our first case in Mojave County was swabbed. Their specimen came on October 21st, and that was in a Kingman resident. So far we've only had 5 reports, and they're coming from Kingman and Lake Havasu City area, and I'm sure that's going to grow here with time. Zika virus, since it's emerging, something we should probably touch upon here because there's been a whole lot of work on our end with Zika virus and mosquitoes and everything involved with this emerging illness. To date, we have received 8 reports of Zika virus infection in folks in Mojave County. And based upon their clinical presentation, meaning whether they were symptomatic or not, and their travel history, and of course, in terms of the possibility of sexual transmission, also their partner's travel history and clinical presentation. Of all those individuals, of the 8 individuals, only 2 really would have ever been considered at any risk of Zika virus infection. The other 6 were not considered to have any risk of being infected with Zika virus because they simply couldn't have picked it up. And there was nothing that they had done that would enable them to pick up the infection. None of them had positive lab results, and we were able to rule all them out as Zika virus infections. And if you're curious here, of those 8 cases, 2 were male, 6 were female. Of those 6 females, 5 were pregnant. So a lot of the tests were coming in through the OBs, which is a good thing. Some of them, however, were coming in through the emergency room, which is a little bit unique. Of those 8 cases, only 1 was symptomatic. And that individual had not traveled anywhere. And the reason they were being tested is because they had aseptic meningitis, and nobody could figure out why. And so they were tested for Zika, and actually their tests were later declined because they didn't have the travel that would have associated them with the infection. But they were also ruled out on the other side for West Nile virus infection and also chikungunya and a whole battery of other tests there. So that's the only one that we've had who symptomatic so far. Of those 8 individuals, only 3 have had travel to an affected area. There were others who had traveled to Europe. There were others who had traveled to other places in the United States, but nowhere where there's any sort of transmission. We are continuing with our mosquito surveillance. The environmental health crew is continuing with mosquito surveillance. And I just want to stress that so far, we have not found those mosquitoes that can be vectors and that can transmit this virus. So we found plenty of other mosquitoes, including mosquitoes that can carry West Nile virus, St. Louis encephalitis, Eastern equine encephalitis, but we don't have those mosquitoes yet identified in Mojave County. And the one thing that we need to be really careful about is they have been identified definitively in at least 9 different counties. We determined that it was a community-acquired pneumonia, and it didn't come from the hospital. But what's so significant in all of that is if it did come from the hospital, if that individual had picked up their Legionnaire's disease in the hospital, it would require quite a big, robust response on our end. We would have done a whole lot of case finding. We would have reviewed a whole lot of records over the past 6 months and looking forward to the next 6 months. And had we had any additional cases or areas of concern, then there's a whole nother level of environmental testing and clearance that you go through. So we dodged a bullet there, but it's another thing that we got a lot of good practice with. Questions?
Did you identify the organism for that case in mid-October for the community-acquired pneumonia?
For what, the outbreak?
The community-acquired pneumonia, was the organism identified?
No. Oh, the one in October, the hospital
Correct.
possible one? It was Legionnaire's disease
Community-acquired. From the community?
from the community. Yes. Yes. So if we were looking for hospital-acquired infection, we would have looked at the person's onset date when they first got sick, and then looked to see if they had been hospitalized at that hospital for 2 days prior to that onset, all the way to 10 days prior to that onset. If they had been hospitalized that whole entire time, then they would have been considered a hospital-acquired Legionnaire's disease. This individual's onset, in the end, it was very tricky to tease it out because of what he actually presented for, but the onset, and ADHS was in agreement with this, was probably the day after he was hospitalized. So that got us out of that zone there. But he definitely had Legionnaire's disease amongst a number of other problems.
Well, thank you very much for your very in-depth report, and thank you for the work that you that supports this.
You're welcome.
Thank you.
I enjoy it.
Before Adrian begins, I would like to, if most of you don't know, I will let you know now that you are now the Board of Health of a nationally accredited public health department. We are one of the first public health departments in Arizona to be accredited, and we're out of one of the first 150 out of 3,000 health departments in the United States. So we're very proud of the accomplishment, and we owe a huge thanks to you guys because a lot of you showed up at the site visit and really helped us get over the finish line for that. So I don't know how to say thank you to all of you. I just really sincerely appreciate not only you coming to these meetings and being a huge support to us, but that day and that site visit and all of the nice things that you said to the site visit team really helped to put us over that finish line. So thank you to each one of you very sincerely. It meant a lot to our team. And we're very proud of our accomplishment. So thank you. And if you'll remember, back in 2013, we did our first community health assessment, and we've been working on the community health implementation plan as a result of that assessment. But one of the, if you will, critiques when they called us after accreditation and said, what did you think of the process and what do you think you could do different? Jeannie and I told them that they need to get the nonprofit hospitals and the public health departments on the same time frame for the requirement of a community health assessment, because we partner with Kingman Regional on this community health assessment. It just makes sense to have one done instead of multi-agencies doing them. And theirs is required every 3 years for the IRS, and ours is required every 5 years. So rather than try to do two of them because of that time difference, we're continuing to partner with KRMC. So that is what we have here for you tonight. We contracted with Pinnacle Prevention out of Phoenix. They did an outstanding job of putting together our community health assessment for us. And then they'll also be working with us on developing our new community health implementation plan. So Adrian is here to go over that with you and talk about the health of our community and what we found 3 years later after the first one.
Good evening. As Patty mentioned, my name is Adrian Udarby. I'm Executive Director of Pinnacle Prevention, a nonprofit that serves statewide here in Arizona to help conduct assessments such as these with various different communities. So hopefully most of you have already received a copy of the report. So you should have this electronically. It is over 100 pages, so I'm going to do my best tonight in a short period of time to synthesize this and really focus on the highlights for all of you. Please feel free to ask me questions as I go through this presentation, and then of course, if there's questions at the end, there will be time to answer those questions as well. So we'll go over just the basics of what a community health assessment is if you weren't involved in the prior process. We'll talk about some of the highlights from the process here in Mojave County on behalf of Kingman Regional Medical Center and the Department of Public Health, and then have some time for some reflections and some opportunities of what this will look like as we go into the health improvement planning process as well. So with that, the reason why this community health assessment is so important is because it helps to identify the health of the residents within the communities here within Mojave County. We reflect on several different data sources. We collect secondary data, but then we go out and we conduct primary data collection by doing focus groups, surveys, key informant interviews. Many of you may have participated in some of those as well. And this helps to guide the health improvement planning efforts and leverage the infrastructure and the human resources and the capital and all of those efforts collectively across the hospital and the public health system to better strategize on some of the approaches and how they allocate resources and how they develop programs moving forward as well. So it's part of those 10 essential public health services, which are part of accreditation, which Patty just mentioned. So really important for accreditation. This is an ongoing process. This isn't just something that happens once, as she mentioned. For the health department, it's supposed to be every 5 years. For hospitals, it's every 3 years. So this is an ongoing cycle that you will now see is just part of how you do business as the health board here in the county. So for the process that we implemented, we follow the MAP process, which is basically mobilizing for action through planning and partnerships. And the reason why we really like this process and this theoretical framework is because it really emphasizes a community-driven approach. So it's not just us as the experts coming in saying this is how things should be done. It's driven by community input, and in the spirit of community input and the strong coalition and collaboration that you already had here that existed here within the county. So in this, there's hundreds of different health indicators that we could look at. We prioritized it down to 35 different health indicators. And then through our community engagement process, we also did surveys, focus groups, and the key informant interviews, and I'll touch on the highlights of those as well. So for those indicators that we did select, our criteria for selection was based upon whether or not that indicator was easily understood by both professionals and public residents, if the data was readily accessible and publishable, if it was available at a county level. And this was a really big and important one because this had to be reflective of Mojave County as a whole. So even though a single agency might have data to share from just their part of the world here in Mojave County, if it wasn't applicable on a county county level, it wasn't something that we were able to include. We also wanted to make sure that our data sources were current, so something preferably within the last 3 years, and that that indicator mix included both physical and social environmental perspectives. So in the report, we tried to color code those indicators for you so it would be easy to find, and we stratified it by mortality, morbidity, healthcare access and quality, health behaviors, social factors, and the physical environment. And a big emphasis for accreditation especially is a focus on those social factors and the inclusion of the physical environment.
Excuse me, Adrian, just one second. I think we're not seeing the slides.
Oh,
Okay.
okay.
Excuse me. I also have a question.
Please, go ahead.
How were these sent to us? You said we received these, we were supposed to have received these electronically.
The report?
I never received anything. I would have liked to have had it before the presentation. I think that would have been appropriate. I don't think this is the way things should be done.
Go ahead and continue. Okay. Okay.
Is there a listing of the group, while we're waiting, is there a listing of the groups that were polled and spoken to in this report?
Yep, there is. Very good. So just to answer your question, Dr. Hendricks, when you do receive the report, if you look in the beginning and the acknowledgments, we have a complete listing there, and there's over 300 different community health partners actually that are included as part of the coalition, some of them actively involved in the meetings, and others more of an ancillary involvement as well, too.
Excuse me, can we get the slides on this screens in front of us? Because they're too small to see from there. But can we get them on the, they're not even
It's not
showing
here at
on
all.
our screens. Oh, okay.
There it is.
There you go. Thank you.
So I'm assuming you're saying 300 different groups? That's throughout Mojave County?
I should say individuals. Some of them are multiple people from one organization.
So they're only in Kingman?
No, throughout the entire county.
Okay.
Yes.
Because you made it sound like it was only Kingman Hospital, and I'm like, that's not reflecting our whole county.
No, this is reflective of the entire county. Good question. So slides are up, and we're good to proceed? Okay, sure. So on this slide here, this just shows for our secondary data points that we look at, best practice recommendations for accreditation is to use the CDC Community Health Status Indicators. And the reason for this is classically, as we've looked at data in the past, we typically compare ourselves to other points within the state. So for example, you might compare Mojave County to Maricopa County, which we've acknowledged now is not an accurate reflection in terms of characteristics, demographics, any of that. So what's fantastic about this new set of indicators from CDC is that it compares what we now call peer communities. So you're being compared to peer communities outside of Arizona, but have similar characteristics to Mojave County with respect to all of these factors that you see listed here. Everything from population size and density, percentage of children and elderly, unemployment rates, single-parent households, median household income, and overall poverty, for example. So when you see the comparisons that I'm about to review with you, these are comparisons with peer counties, which are more like the characteristics and share those characteristics that you have here in Mojave County. And here, and I know it says Gila on that slide, that should be Mojave County. In the report, you'll see things listed for comparison purposes with those peer counties as green, orange, or red. And again, just quick color-coded points of reference for you. Green means that you are doing better in comparison with your peer counties. Orange means you're moderate or very much the same in comparison. Red means Mojave County would be doing worse in comparison with the peer counties. So just to go through some of these assessment highlights, and again, this is a very, very quick snapshot in an otherwise lengthy report, so forgive me if it seems like I'm covering a lot in this short amount of time tonight. So quickly, just a quick demographic snapshot with respect to Mojave County in comparison to Arizona. This is information that you're probably likely already familiar with in terms of your population demographics here, so something to reflect on as I review the data. So in mortality cases, with respect to comparison to peer counties, you'll see that this is all orange and red, so either worse or moderate with respect to peer counties. We don't have any areas with respect to mortality where Mojave County is doing better than peer counties. Most importantly to point out are rates of cancer, coronary heart disease, chronic lower respiratory disease, and unintentional injury. Mojave County is considered to be doing worse in comparison to peer counties. As we break that down now and looking at morbidity, we'll start with those areas where it's red, again, where Mojave County is doing worse in comparison to peer counties. You'll see the rates that are listed here. This one we look at adult obesity rates, and then we're also looking at a lot of our WIC data for, we have great WIC data for our low-income families that participate in the Women, Infants, and Children program, so you'll see that reflected towards the bottom of the chart as well. As I continue on, this is where Mojave County is doing moderate with respect to some of those morbidity indicators in comparison to peer counties. So it would be about the same when we reflect on adult diabetes, for example, osteoporosis in the Medicare population. And then this is all those areas where Mojave County is actually doing better in comparison to peer counties. So some really great points of interest to think about where you're really strong. So for example, incidence of gonorrhea and chlamydia, HIV incidence and prevalence, doing much better here in Mojave County in comparison to your peer counties. As we move into healthcare access and quality, when we looked at older adult preventable hospitalizations, this is where Mojave County is doing worse in comparison to peer counties. Also in primary care provider access, likely much of this is not a surprise to any of you serving on the Board of Health. And then when we look at health behaviors, some of the areas where Mojave County is doing worse is adults smoking tobacco and teens smoking tobacco. Areas where we're moderate, adult binge drinking, and then areas where you're doing better is teens using marijuana. You could reflect that there's other things that they might be using, but it's still, it's something to show improvements in. When we then move into social factors, we break that down, of course, by gender and age. Areas where Mojave County is doing worse is people living in poverty, children living in poverty, much of which you're probably already familiar with. Moderate is single-parent households, high housing costs. Areas where Mojave County is doing better is your school dropout rates and people 65 years and older living in poverty. And then when we look at the physical environment, areas where Mojave County is struggling more is child food insecurity and food insecurity in general. Moderate would be, for example, people living within a half mile of a park. And areas where things are better is liquor store density, for example. So that is a quick snapshot of the secondary data. There is much more, and it's very lengthy in the report. So when you receive that, you'll be able to enjoy some nightly reading with that information. But I'm going to move into the community engagement piece and talk about how we captured community input into the process as well. And what's really important is that we don't weigh one heavier than the other. So we look at the secondary data, but then we go out and we survey and we talk to the community and we bring all of that together to help inform our decision making. So in the community survey, we reached over 1,000 members of your community that participated in the survey across the county. Highlighted in bold is the greatest number within that category. So most of the people that took the survey were female. This is something that we see across the state whenever we do this. It's really hard to get males to take surveys, so a greater proportion of females that take the surveys. By age, most of the people that took the survey, about 24, almost 25% of them were 55 to 64 years of age. Almost 82% were white or Caucasian. Almost 32% had some college but no degree. And then in terms of city of residence, almost 42% of them resided here in Kingman, followed by about 22% in Lake Havasu City, about 11% in Bullhead City, and then you'll see that it follows on down there. That community survey was shared and distributed through social media, electronically, through paper surveys, at community health fairs, community centers, so lots of different avenues to encourage participation in the survey. Some of the highlights then that we got from the survey is that individuals said the top 3 health challenges that they felt that they faced as an individual were obesity and overweight, followed by back pain, and then followed by joint pain. So this is their perceptions of the health challenges that they personally faced. When they had to reflect on the health challenges that they perceived in the community, that the community faced, they identified drug addiction as number 1, obesity and overweight as number 2, and mental health as number 3. Moving into the focus groups. So focus groups is our way to collect a little bit more of that qualitative data. We did 7 focus groups. We had a total of 52 different members of the community that participated in the focus groups. We held those in Kingman, Bullhead City, Lake Havasu City, and Dolan Springs. And then 2 of those 7 focus groups were held in Spanish, so to reach our Spanish-speaking families. So the themes, we analyze and we take out the themes from those focus groups that we found, and some of those themes were overall, focus group participants felt that there was great strength and value in the small, close-knit communities here in Mojave County, and they really valued that. Other than that, they had great concerns with mental health and substance abuse, access to quality primary care and specialty care services, and then felt that there was a need for improved emergency medical services. So that whole system, it was frequently mentioned, is overburdened and overstressed. And some of the quotes from the focus groups you'll see on there, for example, there's definitely an opportunity to better link mental health and substance abuse. Or this quote, it's such an intimate personal relationship, but it doesn't work if I don't trust you. It's stigmatized when you do seek help, you feel ashamed, and then to have a new doctor every 90 days and have to repeat yourself, you've already lived it, and then you have to relive it again and again. So some of those experiences that are very personal that they shared in these focus group discussions. We then go into key informant interviews, and the purpose of the key informant interviews is to get a cross-sector perspective from key leaders in the community. So we were able to get 13 different organizations and 14 individuals to participate in our key informant interviews. These are the organizations that participated in those: Bullhead City Police Department, Mojave Substance Abuse Team, North Country Healthcare, Wallapai Tribe, Mojave County Superior Courts, Treatment Assessment Screening Center, Kingman Regional Medical Center, Mojave Mental Health Clinic, Havasu Regional Medical Center, Cornerstone Mission, Kingman Unified School District, and Bullhead City. We did try to reach out.
Can I stop you for a second?
Please, yeah.
Actually, I've had 3 other questions that I wasn't able to ask because you were going way too fast.
Go ahead.
On this question, is there any reason why the 2 hospitals in Bullhead aren't on the informant interviews?
Yeah, we reached out to all hospital leaders in all of the 3 major areas, and some of them just couldn't get back to us. We got moved around a lot, so having to complete the health assessment by June 30th, there was many that never returned our phone calls.
Who did you speak to?
I don't know individuals by name off the top of my head. I'd have to look at the list. Sure, absolutely. Yeah. Was there other questions that you had as well that I could answer?
I truly don't remember them.
Okay. And don't hesitate to interrupt me moving forward if you have other questions. So some of the themes that came out of the key informant interviews, again, they emphasize the strong existing collaborations and the value of all these different organizations and individuals that are already involved in this process from the prior community health assessment and community health improvement plan. Please.
I do have another question.
Go
I
ahead.
just remembered one of them. The preventable hospitalizations, which criteria did you use for that?
I would have to look into the report, so I will look at that at the very end and I can answer that for you, absolutely.
The other question, the focus groups? You said there were 7?
Yes.
Where were they held?
Kingman.
No, I mean,
Oh.
how many in each place? I'm sorry, I didn't make the question clear.
Sure, so we did 2 here in Kingman at Kingman Regional Medical Center. We did Regional Center for Border Health. We did one at a primarily Hispanic Catholic church and the public libraries. And then Dolan Springs was at a little makeshift community center that they have there.
And how many of them were in Bullhead and how many were in Havasu?
We had 2 in Havasu, 2 in Bullhead, 2 here in Kingman, and the one in Dolan Springs. Yeah.
And then there was also a question somewhere back along the line where it had number of respondents, and I think to something, and I think you had 300 and some odd respondents from Kingman, 200 from Havasu, and 100 from Bullhead.
Yeah, our survey respondents.
Okay, and who were they sent to?
That I can give you the entire list. So most of that was shared with the electronic copies were shared electronically online through community partner organizations. Everybody who participates is in part of this coalition, and we can make sure you have that list. In addition to the paper copies, were done typically at grocery stores, public libraries, different like community health events that occurred throughout the county during that time as well.
I'm just curious, is because as far as population goes, the majority of the population in the county is actually in the Mojave Valley to Bullhead City area.
Exactly.
Second highest population is like Havasu City.
Right.
Third highest is my hometown, Kingman, but a significantly higher number of respondents. I don't know, I'm not sure why. I mean, are the people down in Bullhead that much less interested in things, or is there less outreach when this was done? Was this done with less interest on the part of the department? I don't see the I would like to know where the disconnect is so that I could possibly do something down there to improve that. I've spoken with the administrators at Valley View Hospital about the last one we had, and I was told that there was very little coming from the county as far as requests for information or who to talk to.
Yep, I definitely agree that we would ideally like our survey respondents to be more reflective of your population demographics as a whole, and there definitely was greater participation in Kingman than those other areas. I can only attribute, and this is just assumptions, whether it's the reach of the community partners that help to distribute and communicate the survey out in those communities. I do think the fact that the hospital that's participating in this is centered here in Kingman, and that plays a big role to talk about how important it is to have the hospitals as a key player in all of this and communicating that out into the community. So I think lesson learned for the next go around is to get those other hospitals in those areas engaged in helping to communicate and share the information. Okay. So continuing with themes for the key informants, I mentioned strong existing collaborations, but it was mentioned that there is limited financial and human resources that greatly impacts the ability to be effective. Substance abuse and mental health, they also see as key issues, and then the multitude of chronic diseases that are seen out there are key issues. So one of the key informants was quoted as saying, "The view throughout the community is that diabetes is inevitable, that I'm going to get it no matter what." And so trying to reflect on that and consider what can we do about that perspective. So just to summarize everything now, overall key findings, these are the strengths that were identified through this process. That existing coalition and collaborative efforts that are tackling and trying to address these needs is very strong here and definitely an asset in Mojave County. You have wonderful, beautiful access to outdoor recreation. You do have lower incidences of infant mortality and many cancers, not all, but many. And you have a high availability of diverse healthcare services as compared to other rural counties. Some of the alarming health trends, many of which here you're already all familiar with. Men and women here in Mojave County are dying earlier in life than their counterparts that are residing in similar communities. There's higher rates of mortality. Some of the leading causes of death include chronic diseases, which have been shown to have the greatest financial impact due to high treatment costs, low worker productivity, and higher rates of disease risk factors, such as overweight and obesity, especially among the low-income residents here in Mojave County. Some of the existing social determinants of poor health that we really wanted to reflect on: higher rates of individuals and children living below the federal poverty level, higher rates of low-quality housing with low rates of home ownership, higher crime rates than peer counties, higher unemployment, and higher percentage of adults reporting inadequate social support, and higher percentage of residents having limited access to healthy foods and living in food insecurity. So opportunities that we'll be reflecting on with this coalition moving forward as we move into the community health improvement planning process is access to specialty care service and primary care providers, access to quality substance abuse and mental health services for the underinsured, strategies and support services to better facilitate culturally competent communication between patients and providers, as well as to support care transition, and increase public and provider awareness of available services using diverse outreach and engagement strategies. So this is the snapshot that you'll find in the report when you receive that, but what additional questions do you have for me about anything that I shared tonight? Okay, great. Well, I look forward to being in touch with you again as we continue with the planning process, and thanks for the opportunity to share.
And thank you for the report. Thank you for the report, and we look forward to receiving the report. Next item is on the agenda is call to the public. Okay. And next order is adjournment.
So moved.
So moved. Okay.
I'm good at that.
Is there a second?
I second.
All right. Then the meeting is adjourned.
Thank you, Frank.